So without any further ado, I'd like to introduce our first speaker, Dr. Neera Singhal, who will be speaking on transitioning to DMEK. Neera?
This audience does not really need to be sold about doing DMEK. We're all here for that. But transitions are never easy. So let's just take a few minutes to remind ourselves why we want to make that transition. Well, we know with DMEK, our visual outcomes are better. They're earlier. Our incisions are much smaller. In fact, we're doing now sutureless DMEK. The rejection rates are much lower than DSEK. It's been shown to be about 1% when patients are maintained on a low-dose steroid. And really, in terms of costs, our costs are very minimal. But as with any new technique, there are barriers. So unlike DSEK, with DMEK, there's a whole new skill set that we have to learn. And it's a very steep learning curve. So in addition to tissue preparation challenges and tissue insertion challenges, we also have to keep in mind the volume of surgeries that we need to do in order to maintain excellent outcomes. And change is never easy, and I think most of us in this room are familiar with Prashaka's stages of change. And I would say everybody here really is in the contemplation and hopefully preparation and action stage. There's really never a convenient time. I would recommend setting a date, and I would set a date with your first case after your educational objectives have been met, and then have an action plan. Once you start doing your cases, it's really useful to go back and review your outcomes. And I find that recording the surgeries is a very useful technique. We're really lucky we live in a time where we don't have to just attend lectures. Really, you can watch almost anything on video on YouTube now. And in fact, our course is going to be available online as well. So other ways you can do this is structured learning, and everybody here is doing that. As much as possible, I think it's really important to standardize your technique, and it helps with your success in terms of your results. And for those of us who prepare our own donors, I think it's really useful to get a handle on how that tissue feels and practice the donor preparation on your own. I would recommend preparing 10 practice size if you can in a wet lab prior to actually booking your first case. And in terms of mentorship, you don't necessarily have to have someone sitting beside you. Most of us don't have that luxury. I think having a virtual mentor is also a very useful thing, and I think all of us here today would be happy to help you with your transition if need be. So just a word on volumes. There have been some articles that have shown that you have to do a certain volume of cases in order to go through your learning curve. And I think this is very surgeon dependent. So Mark Terry, I think, said it very well a few years ago, where he quoted, I'm going to quote this, "Some surgeons can do 1 or 2 DMEKs a month and be very good at it, and others will have a miserable time reaching and maintaining the necessary skill level with only 1 or 2 cases a month, but only the surgeon can make that decision. However, if you want to offer DMEK, you have to commit to going through your learning curve." And I think that's very true. So in addition to knowing how to do the procedure, you have to know who to do it on. So in terms of your very first cases, you don't want to have a patient ideally that's had a vitrectomy before. I think it's very difficult in terms of pupil management. I would book pseudophakic Fuchs patients, make sure they have a normal pupillary response, and try to obtain your tissue that's favorable in terms of dissection. So patients generally over the age of 60 or 65, they tend to be easier to dissect. And so again, for those of us that prepare our own tissue, so I know here in the United States you get the tissue already prepared, but in Canada we don't. And a big stress of the surgery is really the preparation, I found, at the very beginning stages. So if you could prepare your tissue ahead of time, I really would recommend that. It really takes a lot of that initial stress away. And doing it this way, you can actually prepare 90% of it prior to the day of surgery. You can prepare it up to 3-4 days. So here's a video that's showing this. So we're using a Lasix Sloan hoe to dissect Decimes, and then I'm going to use a non-toothed forceps or a tire here in order to peel Decimes down into a taco formation. I'm using a 2mm punch using the technique Mark Terry showed in order to create the window, and then doing a partial trephination. I like to use an 8mm trephine for most of my cases, and then stain the tissue with the Vision Blue in order to be able to remove the rim. So the one thing that will not hold if you do the tissue preparation ahead of time is marking it. So you can do all the steps up to this point, and really takes a lot of the stress away on that first day of surgery. And just a few words on a technique called the Scleral Spurectomy that I've been doing in Toronto. So the Scleral Spur is basically a technique that one of our fellows a few years ago helped develop, and it's a technique that I teach all the fellows that operate with me now, and I perform this on a routine basis. I find that this is a technique that is very quick and easy, and is a very reproducible maneuver in my hands, and has dramatically reduced the incidence of radial traction or tears. So if you are preparing your tissue and you're finding you're not getting consistent results, this is a very useful technique, I find, in order to help reduce the incidence of tears. So I would recommend this for surgeons that are transitioning into DMEK, experiencing a high rate of tears, tissue that seems very friable, and if you're having a lot of difficulties finding that plane of dissection in front of the scleral spur. So this is an example. This is a surgeon, not myself, that was doing his very first case, and you can see, so what we do is we strip the scleral spur with two pairs of a pair of .12s in one hand holding the rim and another pair of .12s, and it comes off very nicely, usually in one maneuver 360 degrees. Sometimes it doesn't, and you just have to regrasp, and by doing this you eliminate that anterior plane. And Schwabe's line, which is where Decimes is attached, is a much weaker attachment, and you don't get that radial traction leading to a high incidence of tears. Thank you.